Hey everyone, it's Dr. Dan Ritchie, president of the Functional Aging Institute, and I am still wearing my coat today because it is really cold here in the Midwest. I think it's even colder where Dr. Emily is. Dr. Emily Splichal was so gracious to come back. Actually, you were our most popular webinar in 2018, so kudos to you. And so far, the biggest registration for 2019, so things are looking up. And today we're going to talk about something near and dear to your heart. I know peripheral neuropathy is something that our audience always is asking about. Hey, how do I deal with this? So if you don't know Dr. Emily Splichal by now, she's the founder of Evidence-Based Fitness Academy, which is now worldwide, global. How many different countries have you spoken in now? Are you up to 30 yet?
I've spoken to 40 countries.
40 countries. All right, great. That is incredible. So before I turn it over to you, just want to set a couple ground rules for everyone. Pretty much the same ground rules we use every week for our webinars. If you have a question, type it in the question box. Any time is fine, but keep in mind I probably won't interrupt until we get to the Q&A. But if you have a question, we want to answer it. If you have a pertinent question, like if Emily shows something, you're like, I have no idea what she's talking about. Could she explain this term? Go ahead and ask that, and I'll interrupt Emily. If you say some term that people don't understand what it is, and everybody's asking, hey, what is this term? Then I'll jump in. Otherwise, I'm going to disappear. I will listen, and then I will moderate Q&A at the end. But also, as we start out, because I want you, the listener, to figure out where the Q&A box is, I want you to type in where you're from. I think last time that you were on, Emily, we had 4 or 5 different countries represented, and our Canadian friends as well. So type in where you're from, where you're listening from. I always love to see that. But Emily, the time's yours, and thanks again for giving us your valuable time.
Of course. So thank you to everyone who is tuning in. I had such a great time last time that I was here when we spoke about fall reduction, brain breath barefoot, a teaser into that concept, which I will be exploring more at the Functional Aging Summit. So if you're going there, please do check out that session when I present that. I know that I'm on video. My Christmas tree is still up, so no judgment on that one. I'm very hard to let go the holidays. So we keep it up until probably February 1st, no judgment. But jumping into this really important topic on peripheral neuropathy, we had some questions on it last time I was on the webinar, and that's where we kind of got into the conversation of let's do a webinar just on this topic and how important it is to understand peripheral neuropathy or neuropathy in general as movement specialists. So we're going to be jumping into that. Hopefully you're going to learn a ton of new information, take notes, and I will make sure that you have access to this PDF after the webinar so that you can reference back at it. Before I jump into it, I do want to thank Dan and Cody and everyone at FAI. Thank you so much for having me be part of your webinar series. I know that they have a choice on who they have be part of their webinar series, so very special. Thank you. And I will see everyone who is at the Functional Aging Summit. Real quick on my background, if you did not tune in last time or you're not familiar with who I am a podiatrist. I'm more of a functional podiatrist. I am a human movement specialist. I do see some patients when I'm not traveling around educating and running my other company, which is called Naboso. And when I do see my patients, I'm looking at them from a very functional medicine approach, a functional movement approach, and then I also do a lot of regenerative medicine, vitamin supplementation, etc. So think of it more as like a holistic movement longevity practice, and that's what I truly believe in. That is my goal through any of the education that I do, through any of the education bodies, is help movement specialists or allied health specialists help their clients and patients really take ownership of their health. And that's going to be the underlying theme throughout this as well, is how can you help your clients take ownership of their health? And if they do happen to have some symptoms of peripheral neuropathy, how can you help them know all of the options that exist for this condition? As mentioned, EBFA Global is my education company, and some other fun stuff along there. So again, we're going to be focusing on peripheral neuropathy, and really the topic of, are we doing all that we can to help our clients that are experiencing some peripheral neuropathy symptoms, whether it's the hands or the feet? So I know I had some people message me and say, well, I have neuropathy in my hands. Are you only speaking about the feet? Whatever I'm speaking about, please know that it is applicable to both the feet and the hands. However, most of the neuropathy that you will probably encounter as a movement specialist will be more so in the feet, because those nerves are the longest and the furthest away from your central nervous system. So they do oftentimes get affected earlier than the nerves in the hands. Does not mean that your client will not have neuropathy in the hands. So to understand this, to make sure that everybody is on the same page, we want to understand what peripheral neuropathy even is. So peripheral neuropathy, according to Mayo Clinic, is the results of damage to the peripheral nerves, hands and feet. It's often associated with weakness, numbness, and pain. Now you can think of it as our nerves are almost like, think of it like a hose. And if you get a kink in the hose anywhere along that line, you start to get a disruption in the message that goes out. Usually where you're getting the disruption of the message or the presentation of the symptoms is all the way at the end of the hose, so where the water would come out of the hose. Even though the kink might be, up in the thigh or whatnot, or you're starting to get some of the axonal degeneration a little bit higher up, it will still present as symptoms all the way at the end of that hose. So some of these nerve signaling disruptions is that you start to see a loss of signals. The analogy is thinking of like a broken wire. You can start to get inappropriate signaling. Now, this is very common in neuropathy, and I want you to understand this, that the amount of getting static on a telephone line or static, if you're thinking of like a TV and you're trying to get into the right station, that's what it is like for someone who has neuropathy and are experiencing what are called positive symptoms. I'm going to go into what that means in a moment, but imagine having just like an annoying into your nerves, and then that's stimulating the brain and your sensation. That's what these patients are experiencing. It can be extremely frustrating, and a lot of them are just kind of grabbing at anything for some sort of relief. And then again, the third way that nerve signaling can get disrupted is that you can get a distortion in the messages that are sent. So just kind of think of those ways to start bringing around your understanding of neuropathy. Now, most of the neuropathies, as I mentioned, are referred to as length dependent, which means the furthest the nerves are away from your central nervous system, those are going to be the ones that are affected first. If you think of where that is, it's going to be the tips of your toes are going to experience it first. Most neuropathy isn't going to start in the heel or in the middle of the arch. It's going to be on the tips of the toes. Now, this is something important that I want to go over as well, is the difference between polyneuropathy and mononeuropathy. You could probably deduct what that means just from the start of both of those words. Poly means many or multiple, mono meaning one. So you could have a client who has a mononeuropathy, let's keep it with the foot, of let's say the sural nerve. So they have an entrapment or they had a traumatic irritation to the sural nerve. So they start to get pain on the lateral part of their calcaneus. It radiates to the bottom of the foot, and they can still have the same complaints of burning, radiating. When they shift forward, they get like a pulling or a catching feeling, which is the nerve stretching. That is going to be a mononeuropathy. People who will have a cast. Casts aren't used as much anymore, but imagine if you had a below knee cast, and if it sits really high under the knee and it's not applied correctly, you can hit the fibular head, and then you can actually get a mononeuropathy of the perineal nerve as it wraps around the fibular head, and it can result in like a foot drop. So those are mononeuropathies that you would typically see. Polyneuropathy is going to be a majority of probably what you're thinking of when you think peripheral neuropathy. Diabetic neuropathy is a polyneuropathy. A lot of the chemo-related neuropathies are polyneuropathies. So we'll be going into that and focusing primarily on polyneuropathy. All of the nerves into the bottom of the foot are being affected. The types of peripheral neuropathy. Think of it as the types of polyneuropathy. There's different ones. Physical injury or trauma. I gave the example of the sural nerve injury, a mononeuropathy. That would be an example of a trauma-related neuropathy. Diabetes is going to be the most common one that you're going to see. Around 60% of diabetics experience diabetic peripheral neuropathy symptoms. That's extremely high. That doesn't mean that they have total loss of sensation in their feet and they have an extremely high fall risk. It could just be an occasional tingling in the tips of the toes that they might not even bring it up to you. That would still be considered part of this 60% of diabetics with neuropathy. Autoimmune diseases, huge one as well. So anything that is inflammatory. Some of the most common autoimmune diseases that are associated with neuropathy, this chronic inflammatory demyelinated polyneuropathy. Ooh, that's a lot of words. So essentially they're getting an autoimmune attack to the myelin that surrounds the nerves. Other ones that you might actually see a little bit more frequently would be lupus or associated with rheumatoid arthritis as well. Nutritional and vitamin imbalances. You might see this with alcoholism. Vitamin B12 is probably the most commonly known. I actually do not see a lot of nutritional associated neuropathy in my office. Very, very little. If you went to a neurologist or I had a patient with neuropathic symptoms and I sent them to the neurologist, I don't know, they just go straight to thinking it's nutritional. Very, very few are going to be nutritionally associated. However, what I will mention with the population associated with FAI and probably who a lot of you specialize in, as we get older, our diet changes, our ability to absorb nutrients changes. So you actually might want to have on the back of your mind that there could be some nutritional deficiency associated neuropathy as your clients start getting older. So do keep that on the back of your mind, please. Chemo-related, huge one. Had to put an asterisk next to that one, because as you start to see a rise in, unfortunately, the cancer rates, I don't know statistically offhand, but it's probably 1 in 4 will experience some sort of cancer in their lifetime. I mean, the rates are just ridiculously high, which means the chances of you having a client who has undergone chemotherapy is going to be higher and higher. So understanding chemo-related neuropathy is also really important. I will go into that much more. Idiopathic, interestingly enough, is something that I see a lot in my office. It's a really frustrating neuropathy for these patients because they're essentially going to the neurologist, having every test possible to determine why are they experiencing numbness and pain. And essentially the neurologist is just like, I don't know. We'll call it idiopathic. No known cause. I don't know why your body happened to attack your nerves. So that you could almost put under autoimmune. A lot of it's actually stress related. So understanding that one's really important. And then HIV and AIDS, you may or may not. When I was in residency, we saw a lot of that. So it was important for me to understand the associations of HIV, AIDS, and neuropathy. So another big topic related to this. So we understand polyneuropathy versus mononeuropathy. We understand the types. So if we have our clients, is it diabetic? Is it chemo-related? Is it idiopathic? And then what does that mean as far as the programming and then treatment recommendations for these clients? Is it reversible or is it irreversible? Right? Is diet important in it or is diet not? So we want to understand those differences. Another layer that you want to understand is which nerves are affected by the neuropathy. Huge, huge part that I think understanding as movement specialists, this slide in itself is probably one of the most important. So you can have a motor nerve neuropathy, which is actually much less common. So that's actually good in a sense that it's much less common than the sensory. So most of the neuropathy that you will encounter with your clients is going to be a sensory peripheral neuropathy. This means that they probably cannot feel the vibration coming in. They can't quite feel if something is hot or cold. They can't feel the texture of the ground, but their intrinsic muscles in the bottom of the feet are still contracting. They still have motor control of the muscles of the foot and the ankle. They don't have the sensory, and remember that sensory trumps motor. Sensory trumps motor. So ultimately, you will start to see sensory trickling down into motor deficits, muscle weakness, foot weakness, loss of balance, inability to walk the same way, right? So, but the driver is the sensory. Understanding that difference is really important because you want to make sure that you are training the muscles and keeping those muscles as strong and sharp as you can if it is a sensory peripheral neuropathy. Third one that I'm going to be speaking about towards the end a little bit more, and I think is something really important, especially because we deal with movement and exercise, is an autonomic neuropathy. Maybe you didn't even know that there was an autonomic neuropathy. Imagine what that does to your clients if their autonomic nervous system is not responding the way that it should be. Immediately, you should be going to heart rate, blood pressure, breathing. How is that going to affect the way that their blood vessels constrict and dilate, how they sweat? All of that stuff is affected by the autonomic nervous system. And a lot of the patients who want to keep going back to diabetic neuropathy, which I don't want to keep doing that, but a lot of diabetics with peripheral neuropathy, please know that they also have an autonomic neuropathy. They might not even realize it. It might be low grade. Maybe it's not even being addressed by their doctor, but just know that that's going to start affecting them. Towards the end, I'm going to be going into that some more. Now, this is a slide that I had mentioned briefly. There's different types of symptoms that your clients with neuropathy can be experiencing. There are what are referred to as positive symptoms, and then there's what's referred to as negative symptoms. You could think of the negative symptoms as like a void. The positive symptoms are the ones that we most often think about. Think of them as like a loud or a triggering pain, burning, radiating, sharp, feeling like someone's splashing water on your foot, feeling hot temperature flashes. You can get a sensitivity to texture. One day, a pair of shoes feels good. The next day, they hate those shoes. One day, the socks work, and then the next day, they don't. One day, the orthotics work, the next day, they don't. So those are a lot of the positive symptoms. This is as opposed to the negative symptoms, which is the void. This is the tingling. This is the numbness. When I start going into the treatments, so the treatments that are offered to these patients, as a movement specialist, you should still understand because they all have side effects. The treatments that are recommended for positive symptoms are very different than what should be recommended for negative symptoms. If you have a client that has numbness in their feet or tingling in their toes but has no pain, that's amazing. They only have the negative symptoms. They don't have to deal with the shooting and the radiating and that's really what's driving a lot of these patients crazy is the positive symptoms. So a lot of the treatments for neuropathy targeted towards the positive symptoms is trying to just block the brain from even feeling that sensation. I will go into that in a moment. I had mentioned this briefly as far as the autonomic neuropathy, just to again kind of reiterate what I had said. Some other things that you can see with autonomic neuropathy is they start to get thinning skin. So the skin, particularly to the skin in the bottom of the feet, becomes thin. That is partly where some of the association of diabetic with neuropathy, you have to be very careful about them going barefoot because the risk of them stepping on something and breaking the skin and getting an ulcer and then it gets infected and then they get an amputation, just kind of the host sequelae. A lot of that is because they have a compounded autonomic neuropathy, which is thinning the skin in the bottom of the foot. So let's say it's easier to puncture. Lack of sweat, mention that. Slowed vasodilation in response to exercise, so their BP or their blood pressure might not ever go up. Heart rate might not respond the way that you're expecting with some of your other clients. So we'll again go into that in a little bit. Real quick with the treatments. So the treatments for peripheral neuropathy. If you are currently training a client who has peripheral neuropathy, I'm guessing that you probably want their medication list, understanding if they are on any medication. Most of the neuropathy medications, if you are familiar with these, gabapentin, also known as Neurontin, Lyrica, which is also known as pregabalin. You probably see some commercials on the TV for these medications. Duloxetine, which is a antidepressant. Gabapentin and Lyrica are anti-epileptic medications. So they're anti-seizure medications, which sometimes we find that we get these added benefits to medications, and that's why you will see, oh, why are they using an anti-epileptic medication for neuropathy and for neuralgias? Because they saw that there was this side effect, which would be masked nerve pain is technically a side effect of an anti-epileptic medication, which is why it started getting used, of course, different doses with the peripheral neuropathy. And then the last medication is capsaicin, which is topical. So gabapentin, Lyrica, what I want you to understand with these medications is that if your patient is taking these, they have nasty side effects. I am very slow to put any of my patients on any of these medications. And what's really unfortunate is that a lot of patients are being prescribed these positive symptom medications when they only have negative symptoms. If the patient does not have pain, nerve pain, burning, radiating, and they're only complaining about numbness, they really should not be on these medications, because the sedative side effects of it and the addiction side to these is really high. When they come off of these medications, they have to titrate down. You cannot suddenly cut off any of these medications. The way that they affect, just in case if you're curious, is they are going to start increasing what's called GABA. So it's a nerve calming neurotransmitter. And then it's going to decrease what's called glutamate, and that's more of like a nerve exciting agent. So it's trying to create that balance between GABA and glutamate, which essentially is masking the perception of pain within the brain. So understanding the causes of neuropathy helps you to understand some of these other medications or some of these other treatments outside of pharmaceuticals. Again, understanding, how does this even happen? Why does a diabetic start to get peripheral neuropathy? Why does someone who's undergoing chemo get neuropathy? And then the same thing with autoimmune and with the idiopathic. If we look at diabetic peripheral neuropathy first, again, this is probably the most common that you will see. It is one of the most preventable causes of neuropathy, peripheral neuropathy, and it's one that lifestyle modification is great. So if you are in the business of coaching your clients in nutrition and diet and lifestyle and daily habits and owning their health, diabetic neuropathy would be the easiest one to do that with, because it responds directly to lifestyle. Diabetic neuropathy, the way that you know it's diabetic neuropathy is that it is in a very classic stocking glove pattern. So if you've ever heard that stocking glove pattern, what that means is that it's obviously going to start the most distal, like I said, so that length-dependent neuropathy. Diabetic neuropathy is a length-dependent neuropathy. It will always, hands down, always start both feet symmetrical. If you have numbness in your left foot on the tips of the toes and you happen to be diabetic, that is not diabetic neuropathy. It will be both feet, tips of the toes, symmetrical, directly mirrored, one foot versus the other foot. Okay, so that's really important to understand. As you start to get into the progression of the neuropathy, it's going to slowly start creeping up. You can see from the pictures on here that it starts to creep up, tips of the toes, and then it gets to the midfoot, then it gets to the ankle. Now it's up to the tibial tuberosity. Maybe they're starting to feel it in their fingertips as soon as it starts to get past the ankle. And then it starts to progress from there. You probably won't be seeing a lot of severe or late stage, just like this picture all the way to the right. That's really high up to have that neuropathy. Unfortunately, probably a lot of those clients or patients that have that severe neuropathy probably also have a comorbidity in their vascular system, and they've probably had, not to be a Debbie Downer, but they've probably had some amputation or a series of amputations, which again, not to be Debbie Downer, but it's just the reality of the progression of the disease. That should be your goal with these clients as well, is to help them maintain their function, own their health, so they can dramatically decrease their amputation risk. So understanding what even causes it. I want you to know that diabetic peripheral neuropathy is an inflammatory condition. It is an oxidative stress condition, and it is what's called a microvascular condition. So what's the driver of inflammation? What's the driver of oxidative stress? And why are those two things attacking the micro blood vessels that supply the myelin and the sheath of the nerves? What this is associated with is glucose, uncontrolled glucose. When you have elevated glucose, chronically elevated glucose, the excess glucose in your system, in your blood system, in your circulatory system, starts to glycate. What that means is that it starts to oxidize. When it oxidizes, it forms what's called an AGE, or an advanced glycation end body. Think of that like a free radical. That free radical is targeting collagen. So the free radical attacks the inflammation, attacks the collagen. Now, why it's attacking the collagen is that this protein has a very long half-life, which means that it's hanging around for quite a while, and cells that hang out and proteins that hang out for a while are the most susceptible to micro damage. Now we have big damage, and then you have narrowing or hardening of, let's say, the blood vessels. Collagen, just so you understand the protein, is found in your skin, it's found in your blood vessels, it's found in the nerves, it's found in the bone, it's found in your tendon, it's found in your fascia. So wherever there's collagen in your body, it is being affected by glycation. So this is also, just as an aside, diabetics with elevated glucose that are experiencing glycation and free radical formation, which is every single diabetic or every single person that is not controlling their blood sugar, even a young, seemingly healthy individual, if they start getting spikes because they eat a whole thing of Haagen-Dazs, they're going to get elevation in their glucose, and that excess glucose, even in your 20s, is going to turn into free radicals and inflammation. It's going to start to attack all of that collagen. In a diabetic, particularly, you start to see cross-linking and adhesions, we'll call it stickiness for the sake of the webinar, in your fascia, which means that mobility and the ability to have elasticity within your fascial web actually gets compromised in diabetics with this elevated blood sugar. So mobility work, fascial release, training the rubber band of those clients is also really important. Not just, oh, they might get neuropathy, but what is that glycation doing to that fascial web? So remember that as well, please. All right, so looking at the collagen and how this AGE formation happens, little bit of science here, goes into the Maillard reaction. The whole point of what I want to focus on here is phase one, you have this reaction that's happening. It's starting to get into what's called a shift base. That's step one. It's still reversible. That's the point that I want to focus on, is the formation of AGEs, which are free radicals, to a certain point are actually reversible. So lifestyle modification, vitamin supplementation, and get them to change their diet, because a lot of the damage that might start happening is actually reversible to a certain point. Your phase two, I want you to focus on this because this is happening within days, but actually within months. This is where you're getting formation of this amidori product, and one of the amidori products that you're probably familiar with is a hemoglobin A1C, which is what is measured in a diabetic. So the hemoglobin A1C is reversible, which is why it's measured every 3 months in a diabetic. And if they're changing their lifestyle and they're working with their movement specialists and they're doing what they're supposed to be doing, their hemoglobin A1C should be going down. A good positive marker that they are still in the reversible stage. If they continue to have their glucose elevated and not be compliant, unfortunately, you start to get these permanent crosslinks within the collagen, which leads to the microvascular disease, and then you start to lose circulation to the nerves, the peripheral nerves, and you start to get demyelination of those nerves, hence neuropathy. So the AGEs and microvascular health, real quick. So collagen AGE, crosslinks will produce stiffening of the micro blood vessels. Because we're dealing with neuropathy, it is the micro vessels. Yes, your macro vessels, your aorta, can still get the exact same stiffening and start to get plaque formation. Same thing happens, but I just want you to understand the direct relationship to the micro vessels and the nerves. Glycation of LDL products creates what's called an atheroma. This is the first formation of a plaque, and then you get a decrease in nitric oxide, which means they actually have less vasodilation, which all leads to damage to our poor peripheral nerves. Understanding that this is actually a glycation process, an inflammatory process, and a free radical process means what else could we do for these patients or these clients besides just watching what you eat or exercising maybe, right? Controlling your weight. This is where I turn in my office to different vitamin supplementation. This is where I would encourage you to have that conversation with your clients, because if they are seeing an endocrinologist that doesn't believe in holistic medicine and functional medicine, and they just want to push them on whatever their insulin or metformin, whatever medication they're on, but they're not having any conversation on possible vitamin supplementation. This is where you could come in and perhaps share that information with them and guide them to then explore that option. The key ones that I would recommend that you recommend is Medinex. Medinex is a prescription. This is the activated form of different B vitamins. It is shown to have positive effect in diabetic neuropathy. That's actually its FDA indication. Medinex for diabetic neuropathy. It is shown to decrease symptoms of the numbness and increase nerve growth factor, which means that you're actually getting some regeneration of the peripheral nerves. If they don't want to go the direction of the Medinex, which is a prescription, they can get it from any of their providers. There's also L-methylfolate, which is a activated form of folic acid. Just having folic acid in itself is not enough for these patients. It must be methylated. When vitamins are methylated, that means that they're activated. So you want to look for the methylated form. L-methylfolate, the dosage is on the next slide, but that's going to be 1,000 international units or micrograms 3 times a day. Benfotiamine, this is the activated form of vitamin B1. What it does is it's blocking the formation of the free radicals, which is really good, preventing that free radical formation. R-lipoic acid is one of the best, strongest antioxidants that we could take. Dosage on the next slide. Acetyl-L-carnitine. This is one of the most researched vitamin supplementations for neuropathy. It is shown to increase nerve growth factor, and then L-lysine and L-carnosine. L-carnosine, again, anti-glycation agent. So really, really good for these patients. These would be the doses that I recommend. Benfotiamine, 300 milligrams. BID means twice a day. R-lipoic acid, 600 milligrams once a day. Acetyl-L-carnitine, 500 milligrams once a day. L-carnosine, 1,000 milligrams once a day. L-methylfolate, 1,000 micrograms 3 times a day. This is the little cocktail that I give for all of my neuropathic patients. Typically, it responds a little bit better for diabetic neuropathy because it's a glycation-related neuropathy. However, in those that have idiopathic or chemo-related, because these are all nerve protective supplements, I will often recommend them as well. Now, we're moving on to the second part. Now that we understand a little bit more of the differences of neuropathy, poly, mono, sensory, autonomic, diabetic, chemo, how does this affect you, the movement specialist, and your programming, and what you could be doing from an exercise perspective for these patients? So first little topic is my client has numbness in their feet and was told by their doctor to never take off their shoes. Well, that's not accurate. You can safely take off your client with any sort of neuropathy shoes and train them barefoot. You want to make sure that you are in a clean and controlled environment. You're checking their feet before and after you train so that they feel confident, they feel assured, you feel assured that nothing has happened, there's no break in the skin, they are safely going back into their shoes and leaving your gym or facility safely. You want to focus on engaging the feet because remember, most neuropathies that you will see in your practice are going to be sensory, not motor. Sensory ultimately starts to affect motor, but they still have the active engagement of the intrinsics in the bottom of the feet. And we want to be able to tap into that. Last one, I'm going to go into a little bit more, but you can use the skin of the hand to help bring in even more sensory stimulation. Since they start to have numbness in the feet, you need to go to the other input system in the body, which is the hands. And if you stimulate the hands, you will actually improve their balance. So think of that as a strategy, or we'll call it a hack, to improve the client's sensory information and the way that the brain is processing that information. I went into this on the last webinar that I did. If you're not familiar with it, it'll be quick. But I just want to emphasize on here, which is important to understand, that we have different types of sensory nerves. So if your client has a sensory peripheral neuropathy, these are the nerves that are affected, but not all are affected the same way. So we have nociceptors, pain, thermoceptors, temperature, mechanoceptors, touch, proprioceptors, muscle spindle, GTOs, tension, stretch, right? So those are the four main sensory nerves that we have in our feet. Now they are broken down into two different pathways. These sensory nerves, two of them go to the brain through one pathway, and then two of them go to the brain through another pathway. Many patients with diabetic or with any neuropathy, but with neuropathy, actually have a disruption in one of the cortical pathways, but not the other. So understanding that's important. A lot of the neuropathy that you will see is happening, perhaps initially, in the nociceptor and thermoceptor pathway. If they're experiencing pain, which they are, burning, radiating, hot splashes, cold splashes on their feet, those are thermoceptors. The pain and the radiating, that's a nociceptor. So it's starting to show that the static, remember how I had said in the beginning that the static of the TV or the static of the nerve is happening in the nociceptor, thermoceptor, cortical pathway. That's important to know because that means, you can stimulate the other ones to help control their movement. Get into the mechanoceptors. These are the mechanoceptors, or the touch receptors in the bottom of the feet. Start to get into two-point discrimination, get into skin stretch, get into vibration, whole body vibration platforms for your neuropathic patients. Try to take advantage of the other cortical pathway while they happen to be experiencing a disruption in the other cortical pathway. Can you help them get a sense of their balance and their orientation in space? Because really the biggest concern with any neuropathic client is optimizing functional movement, typically walking, fall reduction, walking optimization. So we want to remember that most of a peripheral neuropathy is sensory, not motor. This means that you can still train the powerful connection between the feet and core for balance. I go into this heavy in my workshop. I'm actually doing a pre-con at the Functional Aging Summit. So if you want to learn more about how your feet and your core are connected and you're going to the summit, please check it out. From a fascia line, the deep front fascia line, your feet are connected into your deep pelvic floor, deep core muscles all the way into the diaphragm. So by using these fascia lines and an understanding of the fascia lines, you can actually help that client take the requirement out of the feet and move it more proximally. If they truly cannot feel their feet, perhaps they can't feel that they're doing what I'm doing here, which is called short foot, but you teach them to do it. So push your toes down into the ground. You might not feel fully what that feels like because you have neuropathy, but guess what? You're doing it right. Keep doing exactly what you're doing, and they're getting an activation in the core. Maybe they'll be able to feel the core because their neuropathy is not all the way up into their stomach. Unless it's like late stage severe, they will be able to feel their pelvic floor and the other deep abdominal muscles. So you have to switch their strategy to controlling their center of gravity in space to be more proximal. You have to look at and understand how powerful the thoracolumbar fascia is then in them sensing shifts when they're walking, because unfortunately the foot is not bringing in as much information as we would like. Now, are there ways, speaking of which, are there ways to enhance the sensory stimulation in the client that has decreased foot sensitivity? Absolutely, 100%. My 3 go-tos for this is 1, release the bottom of the foot. 5 minutes of trigger point release to the bottom of the foot has shown to have an immediate effect on balance. 5 minutes, trigger point release, immediate effect on balance. You could use any tool, a golf ball, a rad roll, or a lacrosse ball, use your hand, whatever it is that will help that client start to stimulate the nerves in the bottom of the feet. At the beginning of the session, I would hands down do some sort of trigger point release to the bottom of the feet. If we go to the right picture, using a whole body vibration. Remember from the slide that had the different mechanoceptors in the bottom of the feet, 70% of the mechanoceptors in the bottom of the feet are sensitive to vibration, 70%. We use vibration not only to know how hard we strike the ground, okay, because impact forces is vibration, but we use vibration to maintain balance when we walk. So if we cannot feel vibration, that in itself is going to contribute to a fall risk for your clients. If they cannot feel vibration because of the start of their peripheral neuropathy or how the neuropathy has progressed, perhaps they still can. You just have to turn the volume of that vibration up and get them onto a whole body vibration platform where you can have different frequency, and then they'll be able to feel it again. Vibration in itself stimulates amazing microcirculation. So I use whole body vibration. I happen to use power plate in my office as a form of regenerative medicine, which means any of the neuropathic patients, they are going on the power plate, getting 10 minutes of whole body vibration, and they will get an increase in skin perfusion, microcirculation, circulation to the tendons, and hopefully circulation to the nerves to some degree. Obviously, depending on how progressed it is, you see different results, but it's still a really good way to activate the nerves. And then finally, going to our picture on the left is going to be Naboso. Just putting it out there that I am the inventor of Naboso, so just take that for what it is. But the goal with Naboso is that it is a 2-point discrimination mechanoceptor mat. We have amazing results in those who have chronic neurological conditions, including neuropathy, so really appropriate with what we're speaking on. And just like the whole body vibration, it's essentially turning the noise up to the stimulus or to the noise that they need coming through their feet. If you have compromised sensitivity in the feet, you have to turn up the noise, whether that's vibration, trigger point release, walk on pebbles, use texture, train on the Naboso mat, use the Naboso insoles, whatever it is, you have to bring that sensory stimulation in, because ultimately it is sensory stimulation that controls motor output. So now, how can I help my client to improve balance if they have peripheral neuropathy? We have 2 more of these questions. I'm going to try to go a little bit faster because I know you guys might have some questions. So if you are trying to help your clients who have peripheral neuropathy, you're doing balance exercises and they're very wobbly on their feet. Different strategies. 1, balance strategy number 1 is use your eyes. Cue your clients to focus on one spot. The more that they're looking around and they're trying to maintain their balance, it's going to throw off their balance. You have to build the confidence in the client to know how to hack their way to better balance. Using the eyes, staring at one spot, step 1. I love doing balance exercises facing a mirror. I know you can judge mirrors in any different way and body image issues and That's really not what we're focusing on here. We're focusing on function. So using a mirror helps the client build kinesthetic awareness. So I 100% recommend doing balance exercises facing a mirror. Balance strategy number 2, use your hands. Your hands have the same mechanoreceptors as on your feet. So when you touch them, touch your hands, touch anything, doesn't matter, put a ball in their hand, you are stimulating the brain, the homunculus, and your touch receptors. Balance strategy number 3, not doing handstands. No, you are doing what's called tension. So if you have your hands together, you're stimulating touch, but what if you push your hands together, push your hands, push your fingertips? Now you just created tension. Or you could say maybe they have a ball in their hand, squeeze the ball, make a fist, squeeze a fist, squeeze a fist. Your arms are straight out, touch the walls, put tension elsewhere in the body, and it will improve the balance. Your final balance strategy is you must breathe. When your client holds their breath, it compromises their stability. Probably a lot of your clients, especially if they have a history of falls, when you do balance exercises with them and they have neuropathy, they're probably holding their breath because they are scared. So what else can I do as a movement specialist to help my clients better control their glucose? You can use exercise to optimize glucose management. Remember, tight glycemic control is necessary to prevent or slow down the progression of diabetic peripheral neuropathy. Your go-to exercise, all exercises are amazing, but your go-to for glycemic control is resistance training, weights, weights, weights. Now, why weights are really good for controlling glycemic levels is that there's an associated increase in glucose in your muscles when you lift weights. Now, a majority of these insulin-stimulated glucose uptake, these receptors are in your muscle fibers. It happens to be called the GLUT4 receptor, and it is the receptor that allows the glucose to go into the muscle fibers. It is stimulated when you do muscle contractions. So one of the best ways to maintain insulin sensitivity and glucose management is really maintaining muscle mass in these clients. Resistance training, even high intensity resistance training, is going to have the highest effect on glucose levels and glycemic indexes. Last topic, and then we're jumping into any questions that you guys have. Sorry, I'm going a little over, Dan. All right, so my client has autonomic neuropathy. How does this affect their exercises? I really did want to mention this as the last part because it might be an area that you're not familiar with, autonomic neuropathy. How is this going to affect my client's exercises? They're going to have altered heart rate variability. If you're familiar with heart rate variability, this is what's referred to as the interbeat variability. It is controlled by your parasympathetic system. Remember, autonomic nervous system, sympathetic fight or flight, parasympathetic rest or digest, and technically you have enteric, which is your gut. All of that stuff is going to be affected with autonomic neuropathy. It is associated with what's called vagal tone. Vagal tone is essentially saying that when your nervous system, your autonomic nervous system goes into a fight or flight sympathetic state, freaking out, right, survival, how quickly can you reset back down to a parasympathetic state? Thinking of how stressed out society is sitting in a sympathetic state. So you want to be getting these clients out of survival, which they might actually be stuck in, and get them into that parasympathetic state, understanding that they have a harder time because of the autonomic neuropathy. Now, this does have an effect with emotional flexibility. I talk about that at the Functional Aging Summit. A lot of them are in a sympathetic overdrive. Now, what you might see when it comes to exercises is that a sit to stand, or like a lying, you're doing floor work and then you're having them stand up and do standing exercises, you're going to see a hypotensive response or a bradycardia response. So you have to be very careful of how you manipulate these clients from floor work to standing work. You don't see this increase or this compensatory increase in heart rate when you stand up, which is what should happen, so you get the blood to your brain. they actually get a hypotensive response upon standing, and this is referred to as a postural hypotension. So just understand that and appreciate it. Oops, sorry, Dan, I lied. One more. I'm totally going through this and I'm almost done. I'm a cancer exercise specialist and see a lot of chemo-related neuropathy. Can you tell me more about the association between chemo and neuropathy? Yes, I will do this in one slide for you guys. So chemotherapy-related neuropathy. This is completely different than diabetic neuropathy, which is a free radical, lifestyle-driven neuropathy. Chemo-related neuropathy is a toxicity neuropathy. It is killing and damaging the nerves because of the nature of these chemotherapy drugs. A lot of them have to do with an irreversible axon damage or an irreversible neurotoxicity to the cell bodies. A lot of oncologists, unfortunately, their priority is not the neuropathy. They don't care. They want to save their patients' lives from the cancer that they're treating. The offset in side effects is not their primary concern. So unfortunately, a lot of these patients are not getting nerve protective supplements. This bottom slide here, vitamin E, according to this study, and there's actually several studies around vitamin E, demonstrated a neuroprotective effect when patients were undergoing chemotherapy. So just understand that this is a toxic one that's oftentimes, unfortunately, irreversible. What can you do through that client's journey if you are working with them while they're going through chemotherapy to help them hopefully offset the risk of it? Or if they do have some chemotherapy neuropathy now, 10 years after the fact, how can you work with them to bring in more sensory stimulation or to better control their movement, understanding the oftentimes irreversibility of chemo-related neuropathy? I'm so sorry for going a little bit longer, Dan.
You're fine. You're fine.
No, I just wanted to go over all these topics because it's so important. I know if anyone has any questions, Dan's going to be guiding you through that. And I will be going over some of these at the Functional Aging Summit. If you're going, we have a booth there for Naboso. I have several lectures that I'm doing. Pull me aside and I would be more than happy to go in any tangent questions that you might have that we don't go over today.
Yeah, just one more reason you should register for the summit, since Emily's leading 2 sessions and a pre-conference. I'm going to jump into a couple questions here. We've got probably more than you can answer in the next hour, so we'll do our best. What is the optimal hertz on the power plate?
Yes, so good question. Actually, the lower hertz are better. So every plate, depending on the plate, the personal power plate is fixed at, I believe 30, is fixed at 30. The lower or smaller muscle groups, so the muscle groups of the feet actually vibrate at a lower frequency. So any plate that can go lower to like 20 hertz is actually matching the muscles of the feet and the lower leg. When you start getting into 35, 40, 50, that's more your quads and your glutes. It's higher up in the body. So try to bring it as low as you can.
Okay. Christy asked, by you stimulating their hands, are you in turn triggering sensory nerves in the feet?
Yeah, so they would be different. If you, let's say you have neuropathy in the hands and the feet, you can put the hand on the whole body vibration and get the stimulus that way. You can put the hands on the Naboso mat, you can put the feet, but you're not going to get, if I stimulate hands, oh, my feet nerves are going to wake up. What you will see, what I do want to add to that, because that was a really good question, is if you actually stimulate one foot, a lot of the research shows that you get contralateral effects, which is, to me, that just shows how brilliant the body is and how protective the body and the mind is to human movement. Stimulating one side of the body, you will often see it carry over to the other side.
Yeah. I saw, we looked at a lot of research of athletes with like broken feet and broken legs and, like, well, what do we do with them, right? And a lot of research we saw was if you train the healthy leg, the atrophy and actually the deterioration of the injured leg is less, right? So they recover a little bit quicker. So yeah, that totally makes sense. CA, not sure if that's an abbreviation for someone, says 5 minutes trigger point release has immediate effect on balance. Is this just for people with peripheral neuropathy or anyone struggling with balance?
Yeah, I would use that strategy with anyone who has a compromise in balance, regardless of the age, regardless of the medical condition. That you think of that as like your go-to. The research study, and if anyone's interested in any of these research studies, just message me, was in older individuals is where they saw that greatest effect.
Okay. And I'm just going to say this for everyone because I think we had 3 or 4 people ask. Yes, we did record it, and yes, we will make the recording available. And we'll have the recording up probably in a couple hours on our Facebook wall. And obviously, if you're an FAI member, it will be part of your membership here probably by tomorrow. So yes, we did record it. Anne asks a specific question, looks like about her mother. She says her mother has peripheral neuropathy and wears hearing aids. She has 20/20 vision. She keeps falling down and walking in a zigzag pattern. In fact, she fell down last week while walking on a smooth road. She was going uphill. She was trying to walk faster for fitness and she fell down. She fell down in the yard later that day. I had her go to the doctor, and this morning he told her to walk with a cane and good luck. Any thoughts on that?
Oh, I'm sorry.
What can she do, I think is actually her question.
Yeah, so what is happening is that if you can't feel your feet, and her mother is trying to keep up with the movement of what's happening, some of it could be that there's just a proximal muscle weakness that, her mind is trying to go faster than maybe her muscles can do. And then because she can't feel her feet, she's not getting the most accurate foot placement, which then is what's going to contribute to the fall risk. I would say to start doing a lot of what we had said, get her to start connecting to the feet through whole body vibration, get a personal plate, have her barefoot or train her to start making sure that not just the sensation coming in, but the hip muscles are strong enough to ambulate and to carry her body. And then it could honestly be some levels of dual tasking, which we went into in the other webinar. Actually, I would listen to the other webinar that I did for FAI, which I believe is still within your archives.
Yep.
That people can reference that on Brain Breath Barefoot, because it could also be a combination of a dual tasking issue. And if she's trying to make decisions to navigate her walk and she has everything that I mentioned, that can start to contribute to a fall risk. She has to be very careful with the cane manipulation. If you give a foreign object to someone and now they have to navigate the cane, that can throw them off as well. So yeah, I mean, that's what I would suggest is listen to the other webinar and then try some of the things that we mentioned here. And it's going to have to be an everyday lifestyle, little tips for her. But I'm sorry to hear that about your mom.
Denise asks, how would restorative yoga affect these symptoms?
How would it help or how would it compromise?
How would it affect these symptoms, she says?
So I think anything that is bringing an awareness to the body, to me, yoga is a mind-body mobilization technique, which is great. Getting them barefoot in a yoga practice is really good. Is it reversing? I don't know. There's a lot of research around Tai Chi and fall risk. Actually has a stronger fall risk efficacy than some of the yoga practices. But I think anything that gets people barefoot, gets them connecting to their body internally, mind, body wise, is really good. And we know that there's balance exercises that are incorporated through different yoga practices. I would say it would be a good adjunct to the entire program that you would have for that client.
Okay. All right, we'll do 2 more questions because I know we're about to go over time. Terry asks, is shrinking or muscle wasting of the legs a symptom of peripheral neuropathy?
Yes. So when you have, I didn't focus a lot on motor neuropathy because it's just probably much less common than what a lot of the people will see. But if you've ever heard of Charcot-Marie-Tooth, or if you want to just Google Charcot-Marie-Tooth, that is a classic motor neuropathy, and they get muscle wasting. So muscle wasting or thinning, shrinking, kind of in the words that were asked, you start to see really almost like, not a peg leg, but I'm just at a loss of words right now, where all the muscles of the lower leg start to thin out. That would be the sequelae of a long-standing sensory neuropathy. It ultimately will start to affect the motor nerves because sensory affects motor. However, if you do happen to have a true motor neuropathy, classic symptoms is you are going to see muscle wasting of the lower leg. So the calf and all of those muscles become really thin.
Okay. All right, last question. Sharon asked, what's your thought on having clients stand on an acupressure mat?
So that would be, it would be almost similar to what we're trying to do with Naboso, but it's a louder, I mean, that's a loud stimulus, where if they truly have neuropathy, like a full neuropathy, they may not truly feel what it is, and you just want to make sure that the thin skin on the bottom of the foot is staying intact and you're not getting any irritation. So, you know, I think that they're great for a healthy individual. When you start getting compromised skin integrity, then just kind of tread some of those areas with caution a little bit. Sometimes louder stimulus is not always better, depending on the client or the individual. If they tolerate it well, you know, in general, I think they're good. Tread with caution, especially thinning skin and neuropathy.
Okay, great. Well, thanks again for your time today, and thanks for coming out to the summit in June. We had folks from Canada, all over the U.S., Puerto Vallarta, Mexico. I'm quite jealous of your weather at the moment. Belgium, Norway, Scotland. So several different countries represented. That's very cool. And over 100 people on live today. And if you're on the recording, just hop on Emily's website here, ebfaglobal.com. You can find more information about her and her academy. And we hope to see you all in Albuquerque live in person. So thanks again, Emily.
Of course. Thank you. Thank you to everyone. Thank you to Dan and to all of everyone at FAI.